I said we cannot start while Mahmoud Traina is outside the room. So, all right. So we are reaching the end of toward the end of the presentations. So today I'm honored to be moderating along with my colleague here, Dr. Ali Sahib, who joined us and was a great addition in Kuwait as a structural cardiologist in Kuwait. He didn't join us now, he's been there for a while actually. He started TABIT program and he's doing very well. Along with Dr. Ahmed Bafadl and Dr. Abdurrahman Nabti. I think Dr. Ahmed al-Shihri will not be available today, and Dr. Waleed may be giving a talk for him. So without further ado, we'll start with the controversial topics, and nothing more controversial than asking a surgeon to talk to us about, how to treat coronary artery disease. So with that, a dear friend of mine, Dr. Qasim Alabri, was I met him actually in a couple of meetings and was impressed with his surgical skills, and he will tell us about that.
Thank you, Ahmed. Thanks to the scientific committee for this invitation, and I was naive enough to accept this topic, so I just realized how controversial during the last live case when everyone disagreed on when to do the PCI. But swimming with the sharks sometime, it's a good idea. So my name is Qasim Alabri. I'm a surgeon from the National Heart Muscat in Oman, and I'm going to talk to you today about if you have a coronary artery disease and aortic valve stenosis, what do you do? My only disclosure that I'm a speaker for Edward Life Science. We go back to the main trials that compare SAVR with TAVRs, whether the main trials or the international registries. You can see the prevalence of concomitant CAD with aortic valve stenosis getting up to 70%. And yet, not much of attention was given during those studies to address what do you do with concomitant coronary artery disease when you have a severe aortic valve stenosis. From the surgical history and surgical paradigm, all what we know, if you have a concomitant CAD, it must be tackled at the time of surgery. You don't want to open someone's chest twice to fix a leftover coronary artery disease. And we do think that putting the patient on pump to fix the aortic valve and leave a significant coronary artery disease might not be very pleasant when you try to come off pump later on. From the STS database, concomitant or combined AVR coronary bypass grafting has a mortality of 2.7%, which is not really very high if it's done with the right hands. From the TAVR paradigm, unlike SAVR, concomitant CAD can be tackled differently. It can be staged, less immediate implication on the hemodynamics. In fact, it might give you more radiation and more contrast. And we have to keep in mind putting a TAVR valve might give you a coronary access issue down the road. So the question, do we need to treat? The first study that looked into this is the activation trial, and it showed that there is no significant difference between those who just got TAVR or TAVR with PCI. In fact, it showed increased risk of vascular complication in those who got PCI. But we have to be very careful with this study because this one, it has a very small sample size, 100 on each arm. It was very slow recruiting study from 2012 to 2019. Perimeter stent was used in this study, and also no physiological assessment was done. And most of the vascular complications were actually on the cut down, which is, I don't think it's done anymore. So not much to conclude from this study, but unfortunately that myth continued until this study, which is the first randomized trial came, the NOTION trial, which compared PCI with TAVI or conservative treatment. It showed better outcomes when you do a PCI ahead of times, and still it showed more bleeding risk. PCI with TAVR was superior in most of the subgroup analysis. And here, in this slide, the only remarkable thing, it's the PCI was superior in almost everything except in the diameter of stenosis, less than 90%. where they relied on FFR assessment, and it tells you that FFR in the presence of severe aortic valve stenosis might not be very accurate. Regarding the sequence, this is from the REVASC TAVI registry, where they looked at PCI before TAVI, concomitant or after, and that was the question this morning. And actually, I do agree with the person who said, let's keep the PCR to after TAVI, because if you can see here, the best outcomes are actually from PCR after TAVI. There is another trial which is ongoing, conducted by the Vancouver group, which is a randomized, recruiting a big number of patients that are doing physiological assessment. And I think this study will be a big addition to the concomitant CAD and aortic valve stenosis literature. There is also this study, which is the deferral study on one not to do the PCI with TAVR, which is still ongoing, and I think it will add. So if we agree that we need to do, to tackle the coronaries at the time of aortic valve stenosis, what should we do? If we take this consideration, we have enough literature comparing TAVR and SAVR, and we have enough literature comparing PCI with coronary bypass grafting. So if you just take it very simple, look at the patient, is he low risk, yes or no, and what kind of complex anatomy, and take it from there. Just add to it priority, life expectation, and what kind of coronary anatomy if you need to interfere in the future. From this table, you can see very clearly when you should be more favor of SAVR and CABG, and one where you should be in favor of TAVR and PCI. This algorithm also just reiterates the same thing. And here you can see the advantage and disadvantage of both approach. Basically with surgery, if you do CABG AVR, it's done at the same time, it provides complete vascularization, it adds a little bit of surgical or perioperative risk. With PCI TAVR, you can wait, you can reassess, you can stage, and the risk added to the peri-procedure risk is slightly minimal. This study is the first study that compare actually head-to-head FFR with TAVI or CABG with SAVR. It looked around 200 patients on each group, and it clearly demonstrated that FFR-driven BCI with TAVR was better than a coronary bypass grafting and SAVR. But again, when you cross the two lines, this is from a study that was published in the JACC in 2021. It showed that after you cross 2 years surgery, those curves, they start to cross, and the more durable option started to be more beneficial. But again, if you individualize it to the center and you look on what every patient should have and what abilities in the heart team you have in your center, what treatment is feasible, which one is invasive, and whether you want some more durable option, in a patient-centered team approach, you can tailor all the treatment that you offer to your patients. Again, you need to pick up the right side, the right valve, considering the future coronary access, and I don't think there is a single valve that does not pay attention now to commissural alignment because of the big concern about future coronary access. Regarding the timing of PCI and TAVR, all the three approaches, whether you do it before, after, or concomitant, has pros and cons. So what you should do, a good heart team discussion, and again, you look on what kind of tools do you have in your center and decide on what you do. We at the National Heart Center, I think we have a very reasonable and a very good heart team discussions. We discuss every single patient in the heart team and we decide what to do. And from that, I would like to share with you 4 cases that we have done at the National Heart Center. I picked 4 cases, but we have done many with concomitant CADs. The first patient is 78 years old female. He has excellent functional status. He has previous PCIs. He presented with shortness of breath and angina, echo, severe aortic valve stenosis, and the cath showed 3 vessel disease with some instant restenosis. So yes, he's old, but he was very functional. And we discussed him in the heart team meeting. We examined the patient, we looked at him as a group, and we have decided to proceed with 3 grafts and AVR, despite his age. He had an uneventful hospital stay, and yesterday I texted his son to ask about him, and this is his lifestyle. 2 years after his surgery, he's still enjoying his Mercedes-Benz. The second patient, a 76-year-old gentleman who had a stroke, recurrent TIAs, and he has mild residual neurological deficit. He's in sinus rhythm, no BFOs, no carotid stenosis. So we had no choice but to blame his critical AS and the bicuspid aortic valve as a source of recurrent TIAs and stroke. We did a CT scan for him. CAT showed a mid-RCA lesion, a tight lesion. And we did a CT scan, showed heavily calcific valve. And you can see how ugly that valve. But what struck us in that CT scan, you can see there is an ulcerated plaque that connected to a sinus within the leaflet. With that, we put a strong suspicion that the source of his valve, of his TIAs, is actually from this valve. Despite the push from his cardiologist to do a TAVR on him, I think we're having an alternative option which is less invasive and leaving the coronaries behind. We opted to do a minimally invasive aortic valve replacement, and you can see that ulcer very well there, which I think it caused platelet aggregation or recurrent embolization despite dual antiplatelet therapy. So what we did with him, we did a minimally invasive aortic valve replacement. We put a size 25 biological valve. We did not touch the RCA. He left the hospital on day 3. And for now, I think he's 15 months after his surgeries, no more TIAs. This is the incision, and this is how he walked 48 hours after his surgery. You can see minimally invasive cardiac surgery can really offer a good return to functional status despite his previous stroke. That was how we approached those patients surgically. On the other side, sometimes we are chicken as surgeons. So this 65-year-old female, morbid obesity, osteoarthritis, multiple admission with pulmonary edema, severe aortic valve stenosis, and she has a tight, long proximal LAD lesion. I kept being pushed to operate on her, but when I looked at her CT TAVI, I could only fit a 90-millimeter valve on her. With that body habitus, I begged the heart team to stent that RCA, to stent that LAD, and we put a self-expanding valve. And when I saw her in the clinic last week, I referred her to our bariatric medicine department for weight reduction, structural weight reduction, and for knee replacement, hoping if she comes back, she will be in a better shape. And I promised Dr. Adil Jabri that if she comes back with instant restenosis, I'll do a minimally invasive Lima LAD. So having a backup or a plan B if the patient comes back is very crucial, and stating that to the family, I think it's very clear, is very important. The last patient is 82-year-old female, multiple comorbidities, good baseline functional status. He has low flow, low gradient AS. Ejection fraction was 40%. And he has very bad, like a huge burden of triple vessel disease. We discussed him twice in our heart team meeting, and we turned him down from surgery. So what we did, he went for a BAV, rotablations, drug-coated balloon to his LAD, and again, the same thing was done to the RCA with good results. The patient has been discharged home. We'll see him, this was done 2 weeks ago. We'll see him in a month in the clinic, and then we'll plan, or we stage his TAVR down the road. So these are the 4 cases that I wanted to share that were both tackled either way, surgically or percutaneously. So in a conclusion, coronary disease and aortic valve stenosis remain a complex area with ongoing research. Current evidence supports very selective revascularization rather than making it routine like with the old surgical literature. Heart team approach is very essential to tailor strategies to each patient, and both surgical, SAVR and CABG, or percutaneous TAVR and BCI option should be considered in every patient, considering the anatomy, comorbidities, and long-term goals. Thank you very much.
Thank you. Please come and join us in the panel so we can grill you with the questions as much as we want. Anybody from the audience have any questions? If not, I will start. Please, Dr. Mohammed.
Very nice talk. You see, the problem is I would ask about the first case. The first case was not triple vessel disease, it was a left main.
And the left main, yeah, sorry.
Yeah, so that's the problem. The problem is if you have a left main, which is not included in trial, and activation was an exclusion criteria. And the activation is a negative trial, is an important negative trial. They assume that it's better, but tends to be not better. So, but they rolled out left main. So I find it very difficult when I got entertainment with a left main and critical AS. I think left main is a different story.
Totally. I totally agree with that. Now let's play the devil advocate. Now, why the surgeon feels it's a must to tackle stable coronary disease, even if it is like 50 or 60%, while us currently are forced to treat it medically because of ischemia trial, and all the trials tells you that, stable coronary disease, medical therapy is equal to revascularization.
Well, I think, if you open someone's chest to do his AVR and you think there is a flow limiting lesion, you don't want to come back to it. That's number one. Number two, putting the patient on cardiopulmonary bypass, it might put you at the risk of a perioperative hemodynamic compromise. So nobody took that chance. I took the chance on that patient with a mid-RCA lesion, and it was fine. But the price again here is because I did it minimally invasive. But in the old days where you do sternotomy on everyone, you don't want to bring the patient just for reoperation because of a coronary disease. It's not like you do a TAVR on him if he comes back with angina. It's not a big deal to take him back to the cath lab and tackle it. So that's where it's coming from.
Totally, but you lose in the same time the minimal invasive part because you have to open for Lima and you have to open for Lima.
True, it's in the middle, it's between the percutaneous option and the full-blown sternotomy. So something in the middle.
Mahmoud.
Yeah, great talk, fantastic, really enjoyed it. One thing I just wanted to comment is about the timing, and I think one of the factors that's important, and I agree with you, there's a lot of factors back and forth, is the complexity of the disease.
True.
And so, in general, at least in my practice, if I'm gonna do it, that's, whether we do it or not is one separate topic, but if it's more simple and straightforward, I usually do it before. If it's complex, that I think the patient's gonna be unstable with severe AS, I tend to do it after, and I think that's an additional factor in whether you do before and after, if it's something that's going to need atherectomy, rotablator, like the last case you showed. Yeah. I think you got to make that decision on, you guys decided to do balloon valvuloplasty. Another option is whether you do the TAVR valve, and then you have stability to do the rotablator, but doing a rotablator before in severe AS probably would have been a big trouble if you didn't address the aortic valve.
I have a question about sometimes we are faced with a patient with left main and critical aortic stenosis, and they come sometimes cardiogenic shock. So do you think that treatment would be surgical or
left main with AS?
With AS and critical patients, let's say is an elderly.
Again, to be honest, that patient...
Would you refer her to the cardiologist? Or
we discussed all of them within a heart team meeting, and that patient, actually the 78-year-old female, I was called by the cardiologist at the night of his surgery, trying to convince me that, he said the left main is doable, why not we do him? He's an old, you just look at the age. But we looked at the patient as a team, and I tell you, he's 78 years old. I was quite confident that he will pull through the surgery, and it's better to give him a more durable option. So it's all about the anatomy, the patient himself, and what kind of treatment you want to offer the patient. You take the whole picture together rather than just looking at the anatomy or the invasiveness of the procedure.
Plus, he's still driving his Mercedes, so
yes.
He's doing very well. Dr. Makhdoom?
Yeah, just thank you so much, Qasim. Great presentation. To answer Dr. Ahmed Shati's question about addressing coronary artery disease or significant, it has to be significant disease, obviously, before when we open the chest. I think in the past, we used to take it very easy because it's a sternotomy, and where most of the surgeons are afraid of perioperative event. This is the main driving force, I think, for adding a graft for a valvular procedure, for example. But I think now, with the minimal invasive approach, so many surgeons are questioning this, and because of the ischemia trial as well, and questioning the decision whether we should graft or not. But having said that, putting the patient cardiopulmonary bypass, arresting the heart. It's a big stress, and the risk of perioperative event is become very high. So when we discuss in our heart team, when we discuss similar option, and the patient really wants minimal invasive approach, I make sure that my colleague interventional is standby if there's any event that we can go to the cath lab right away and fix that lesion.
And just to confirm what Fahad did, I did that patient in our hybrid room. In case that RCA gave me a problem, he would just come on spot and stent him.
So I just have a couple of comments here. Thanks for
one
that.
more thing, Ali, sorry. Also, in the surgical field, so many things can give you, so many technical pitfall can give you ischemic changes, some troponin elevation in the ICU. So you don't want to think about that lesion that you left behind. You want to make sure you did everything. That's another thing that make us insist on doing that.
Okay, thank you for the comment. I just want to bring up two questions which I think are very important when discussing concomitant CAD in patients with severe AS. The first question is, do we actually have to treat the coronaries in patients going for TAVI? And as you just showed, Dr. Qasim, there are two trials, the activation trial and the Notion 3 trial. Activation showed really no benefit, but maybe higher risk for bleeding complications if you go with PCI. The Notion 3 trial is different in the fact that the patient population is very specific. They had to have an IFR positive, or you had to have a 90% lesion to be enrolled in the Notion 3 trial. So that they treated patients with very severe CAD. And this is where maybe PCI showed some benefit. So I think the patient population is very important to highlight. Now, if you decide to treat patients with PCI, the other question would be timing. And in our practice, I do support a lot of the comments were made. We usually like to treat the most proximal epicardial stenosis first. And the most proximal epicardial stenosis is not the LAD, it's not the left main, it's actually the aortic valve. Treating the aortic valve first will give you that hemodynamic support to treat the arteries. You don't want to get into a situation where the patient goes hypotensive with rotablation or calcium modification, treating the arteries in a patient with severe aortic stenosis. So my approach, and I guess a lot of the audience here, experts would support only treating maybe severe proximal CAD, and if you do so, think about treating this after the TAVI.
I do agree with you.
Commenting on it's all about balancing the risk of
True.
each one is first and what's needed to be done after. If you have rotablator, you need to have a long procedure, so at the end is a balance. Always discussion about which one is less riskier and facilitating the next step.
Just a quick point. So I look at one of the registries that I did not quote in my study. People who got TAVR first, they almost never had problem because of PCI, because of coronaries later on, or angina.